And hello, welcome everyone. It is Saturday night. Of course, we were supposed to be set up for last night, but life happens. My name's Kane. I'm a GP based out of Mildura, far northwest Victoria, and we are, of course, coming up for some exam preparation for the 2024.2 RACGP CCE Exam. Whew, how's that for a mouthful? Now, hopefully you guys are all geared up and prepared tonight. I do apologise. We all have those days in the clinic where things just blow out. Life happens, and so I appreciate your understanding that we had to reschedule to tonight. Super keen. I've got 3 cases prepared tonight. If people want to jump in and participate, that'd be fantastic for practice before the exam. Of course, if people don't want to, that's also fine as well. And we will talk through the cases that we have prepared and run through the kind of answers we would want to have. Now, of course, before we reached round of cases, we always do a little bit of teaching. Pardon me, give people a chance to come in and join us as well. And I figured with the amount of time we have left, of course, we have the wonders of technology, 7 days left until the 2024.2 CCE exam. So we are coming right up to the time where I want you to be as prepared as possible. You still have some time left to practice, but this should be time to polish rather than time to prepare new things. Now, of course, I wanted to run through then, what are the common traps that people fall into for the CCE exam and how can you best avoid that? And one of the first things that's worth pointing out is overconfidence in familiar topics. So it's an easy trap to fall into for the day, that if it's simple cases, things that you feel particularly confident about, fantastic, but make sure that you don't fall into the traps of complacency, because one of the nuances of these exams is that they're often simple presentations, but sometimes with a little twist to there that has some impact on management. So yes, the patient may have a condition that you know very well, but take into consideration that specific patient's situation, their location, their particular history, any allergies. Focus in and ask yourself, okay, this is a simple case. How does that impact this patient in particular? So some of the big traps there will be comorbidities, or psychosocial factors. So a good effort to dig in, reveal those things and see how does that factor into this patient's management. Of course, the point of this exam is communication, is showing that you know how to communicate to patients in front of you. So you do need to be, time crunch and all, as precise with your explanations as possible. Avoid using any vague terms. Try to not use any jargon that could confuse a patient. And this is particularly important for chronic conditions, mental health, or complex treatments where you need to make sure the patient really understands what it is you're trying to convey. And the easiest way to get around that is, of course, to engage the patient to repeat back information in their own words, as we would do in clinical practice, to make sure they're understanding. Now, the other benefit to doing that is that you'll probably find times where the patient will say, oh, I think I understand this. Can you explain more about X or Y? And that's often a bit of a fishing trip for the patient to actually try and tease out more information that they're wanting to check the boxes that they have to work out, do you know or have you answered the specific points of this case? And of course, inadequate psychosocial exploration. So we acknowledge that these are artificial cases. These aren't the same situation as you would be in clinical practice. We acknowledge it's very fake, but you have to have a certain level of buy-in and factor in the patient's psychosocial history, their emotional context, their emotional cues as well, to really assess that patient, particularly when dealing with mental health, chronic pain, those big ticket items where the emotions come into play as well. So always make sure you have a few questions lined up for that psychosocial history. Open-ended, let them give as much information as they can. And you're going to find, if that's pertinent to the answers, the patient's going to start opening up and giving you information. Remember, they actually have scripts that they're trying to give you the facts. They just need the right question to be able to release that information. So open-ended is a good way to get that. Now, if they lean into certain areas, then add a few specific questions. Often there'll be kind of opening statements for kind of more broader questions, and then, if specifically asked, so look for those red flag items, and feel free to, you do have time on your side, as time precious as these are. So feel free, if you pick up on one of those things, just say, is that something you would like to talk about more today? Or perhaps we could talk about it another time. That gives that patient the opening, as well as letting them say, oh, no, 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 if it's not something that's relevant to that case. Now, helps if you hit the right button. We also have to factor into the fact that at the start of each case, it's going to give you the criteria that the examination is wanting you to fulfill to pass that case. And one of the usual things is address the patient's concerns. So make sure you're actually establishing what those concerns are, what their expectations are, and focus in on exactly what those issues are. If you haven't actually come out of that case having answered that patient's question or fulfilled their requirements, you're not going to do as well as if you've just given more generalized kind of statements. Which also factors into incomplete safety netting and follow-up planning. So again, we acknowledge these are fake situations, and sometimes it's easy to forget to plan that next stage and pretend that the patient is here. And of course, we're not going to solve every single problem in one single consult. That's not general practice. And so we should be factoring in a follow-up plan and safety netting. What are the red flag conditions? What are the symptoms that that patient needs to be monitoring? When do they need to escalate their care? And when would we have a more kind of routine review or evaluation? So big traps, easy to fall for. Please, please, please catch yourself and make sure you don't fall for those. So, of course, we have 3 cases prepared tonight. As we have done previously, I'm going to use Zoom, just as we would on the actual exam day itself. I've just pasted into the chat the link for Zoom if you want to click and join through. I'll give everyone a minute or two to jump into there, so that if you want to participate, click follow through. Please don't do anything that's going to get this channel banned. Hopefully you're all fully clothed and going to behave appropriately, but it's always the joy of trying to do live video. So if people do want to jump in, that'd be fantastic. A trap that I've had reported from a few people, and a quirk of YouTube, is sometimes if you're watching this after it's started, you may not actually be watching the live video and you may miss the opportunities to actually join in. So if you hover the mouse over the screen, you should see the red bar from the bottom come up, and you're looking for a little live icon. You should have the live icon have a red dot next to it. If you have a grey dot, it means you're actually not in sync. So hit that button. It'll take you to the front of the queue. You'll be watching it live, and we'll be able to step through a case, and yeah, you'll be able to participate. Of course, we do have people in the chat here. Again, if you do want to join in, just pasting in again the Zoom link if you want to click and follow through. This will give people a chance to join in with us today to jump in on some cases. Now, no one's in here yet. We'll give it another 30 seconds or so. And of course, if we don't, we'll just step through the case as if we were doing it on the day, or we'll just talk through it, sorry. And hopefully you still get some learning from that. I do encourage everyone, though, this close to the actual exam, to put yourself in the hot seat, to test out your equipment and get that feedback. If people do jump in, if you could provide feedback in the chat, in the comments, as they go along as well, and we can run through it all together at the end. All right, well, we don't have anyone jumping in just yet, so what we might do then is switch this over so that we will have 5 minutes reading on the clock. We will do this case as if someone was jumping in live with us. Case number 1, and our time starts now. so we might turn this into a bit of a case discussion then. Because what we have here is, and what I would take for this sort of approach would be an ask, assess, advise, assist, and arrange kind of approach here. So if we think about what are the systemic inequities that contribute to poorer health outcomes for Indigenous Australians, particularly those in rural areas, we're going to have multiple options here. We have systemic inequities, including a limited access to primary care, particularly in those rural and remote areas, with associated socioeconomic disadvantage as well. That's going to be low income as well as high cost of nutritious food. There's going to be a historical and cultural distrust of the healthcare system, particularly as has been hinted at with previous poor engagements or interactions, and geographic isolation as well, with limited ability to actually access across distances. Additionally, inadequate healthcare infrastructure and workforce shortages is particularly relevant to rural areas, which also leads to increased gaps to consistent care for chronic diseases like hypertension and diabetes, both of which disproportionately affect our Indigenous populations. To assess, we're looking at what specific health disparities might David in particular face due to these social determinants. So he's going to be at increased risk of poorly controlled diabetes and hypertension, which can lead to complications, predominantly cardiovascular disease and kidney disease. His limited access to health services, combined with a high prevalence of chronic disease in Indigenous communities, place him at high risk of complications. Additional food insecurity and limited availability of healthy foods contribute to poorer health outcomes, and his chronic back pain may worsen without regular healthcare follow-up and management. In terms of culturally appropriate management, so how could you actually approach cultural sensitive communication and healthcare delivery in this particular case? Build trust by engaging with active listening, acknowledging past experiences is incredibly important. Use clear, respectful language and tailor your language to David as well. Avoiding medical jargon, if possible, involve an Indigenous health worker if there's one available, or a community liaison officer to provide that culturally appropriate support and address any language barriers. Tailor that education around, in particular, hypertension and diabetes to his cultural context and engage in a gradual change. This is going to be a very long-term plan, particularly focusing on diet and lifestyle, so that it's targeting the things that are actually within his control to some extent to be able to make effective change. So in terms of that practical support and assistance, the assist stage, what specific support or interventions can assist David in managing his health conditions? So arrange follow-up with the mobile health unit for blood pressure monitoring, blood tests, diabetes management like HbA1c checking. Consider arranging telehealth consultations if possible with a GP or chronic disease nurse to improve continuity of care so he's getting more timely follow-up. Providing dietary guidance that takes into account the limited food that is available and the cost of it as well. And if available, connecting him to a community support program that can offer things like transport assistance to healthcare appointments or possibly even subsidised healthy food. For follow-up and community resources, this arranging. So how could you arrange this support? As we've said, schedule regular visits with the mobile health unit. Consider the telehealth follow-up. If possible, try and link in with Indigenous-specific support services such as the Aboriginal health services or co-ops, community outreach programs for chronic disease management, and at the very least, arranging that follow-up with the next time you plan or another person from your team plans to actually be in that region for him specifically, and give him options for health services for urgent issues. So should his condition progress, should he develop complications, he actually has an actionable plan in place of how to approach that. Make use of things like Indigenous health checks to make sure that as much other preventative actions are taken into place. Make sure he's engaged in programs such as Close the Gap in order to subsidise medications and also make sure his immunisations are up to date and tailored to the Indigenous immunisation schedule, ensuring that he's not just up to date with the standard schedule. This is a very sadly common case for a lot of Australians, and I think it's a really important case to highlight the inequities experienced by our Indigenous population. As you can see again though, we've only used 5 minutes of our time here. And I'm sure you sitting out there probably even have a few more things you feel like you could add to a case like this. And so remember, we're not trying to trap you. We're not trying to trick you. This is all things that you're going to encounter day to day. And so don't feel like you're going to get any surprises there. All right. So we might wrap it up there for that case. But of course, we've got two other cases lined up. I will pop the link back into the chat then. So if anyone is wanting to join in again tonight, we have those two other cases there. Link has been posted. Of course, if people don't feel like jumping in, that is also fine as well. We can talk through one more case, and of course, if we don't have anyone joining in from that, we might just end it early for tonight. I appreciate it's a week beforehand, so you probably all have lives and other things to do. Most of you probably don't normally spend your Saturday nights jumping on live streams. That's fine. Of course, if you do want to jump in, posting into the chat again is the link to join us on Zoom. You have 1 week left before the CCE to get as much practice as possible. So I really do strongly encourage you to give it a shot if you're feeling like this is something you would like to do tonight. Now, just while I get the next case ready then. So we'll make this case a clinical encounter. You may have to suspend disbelief with my acting skills, so you've been warned in advance. And again, the link is in the chat. If anyone does want to join and jump in, please pop your hand up and we will go for it. Okay, so remembering we have 7 days left. If you haven't actually been practicing on Zoom with people sitting as well, or just trying to make sure you get the best chance to actually troubleshoot, break things, see what works and what doesn't work, really important, you've tested your audio out, your connection, please, please, please use that hardwired connection. Wi-Fi will work 99% of the time, but not on exam day. It's just one of those things that happens. And we don't have anyone jumping in the chat just yet. So we might then run through the formal feedback from that last case if we jump back across. So the feedback for this case, the competent candidate should be demonstrating understanding of the social determinants impacting our Indigenous health, Indigenous Australians, including an influence of the socioeconomic and geographic barriers. Address systemic inequities with tailored advice based on that patient's unique circumstances. For communication, making sure you're using culturally sensitive explanations and offering support to help build trust in the healthcare system. And addressing the patient's specific concerns empathetically, acknowledging the impact of health inequities. For your evidence-based practice, I want you to be applying knowledge of Indigenous health challenges, including the importance of mobile health services, telehealth and community outreach, as well as, and should be popped into there as well, our Indigenous liaison officers, and providing a holistic, culturally appropriate management plan with a focus on continuity of care and preventative health. All right. So we have another case prepared. Let's get 5 minutes on the clock, and your time starts now. right, so we're into case time now, and again, turning this into a bit more of a case discussion than a clinical encounter. This case really is about handling uncertainty, and on questioning the patient, you're not really going to get too much more information other than kind of vague symptoms without being able to specifically hone down a diagnosis. But obviously, with those ongoing symptoms of breathlessness, shortness of breath, it would definitely warrant further investigation, preferably by ED. But again, the patient here would be Linda would be refusing to go to the ED from the previous statements. So the first thing to tackle with this kind of case is how would you actually approach Linda's reluctance to attend the emergency department? And so the first part is to acknowledge the frustrations with ED having long wait times and validating her concerns. Try and use empathetic statements like, I understand that waiting in the ED can be really challenging or frustrating, but gently explain why, in this case in particular, ED care is important given her current symptoms and the possible risks of delaying definitive diagnosis and definitive treatment. Emphasize that her health and safety is the priority for yourself and for her, and explain that in that circumstance, ED is the best equipped place to actually handle these kinds of medical situations. Surprise, surprise, she would still refuse. And so, how would you actually explain the need for ED in a way that addresses her uncertainty? Clarify that while the symptoms might not feel serious, shortness of breath and low oxygen are signs that need further evaluation. Explain that while it could be related to asthma, there's also a possibility of more serious diagnoses such as more serious infections, pneumonias, cardiac conditions, clots in the chest, things that you can't differentiate without further investigation, but could have more bigger implications in terms of her immediate and long-term health. So emphasize that delaying evaluation could potentially lead to a worse outcome, and that the ED doctors have the resources to give the most timely, safe and effective assessment. Surprise, surprise, she still doesn't want to go. So then it's about how would you actually tackle and target a safe management plan for this condition within the constraints of what you can. So it's creating a safety plan that emphasizes monitoring of the symptoms, organizing investigations as appropriate, heavily documenting all discussions that have occurred, and encouraging the patient, even if she's declining now, to still attend the emergency department. You could encourage use of things like a pulse oximeter if she has one. You'll be amazed after the COVID era how many patients actually do have them. You can organise for a phone check-in either that evening or the next morning, or in a timely manner, or a review in clinic again within 24 hours. Encourage her to have someone nearby at all times as well, so that if her condition does change or deteriorate, there's someone who's able to raise the flag, call for help, and again get her to an appropriate setting. So again, other things that you could try and do would be to arrange a home visit from community nurse or other support service. If available, refer to an urgent care clinic, which can be appropriate for some areas, and I guess would depend on the exact setting for this. It doesn't really specify if there is one nearby, but certainly it's a bit of a buzzword that is worth throwing out in this situation. Reinforce that while the options may provide some immediate support, they're not a substitute for the ED evaluation if her symptoms worsen. And of course, what is her follow-up plan if she does continue to decline or the situation changes? So arrange that follow-up call or in-person review within 24 hours to review symptoms. Advise her to keep a phone nearby and ensure someone's available to assist her. Emphasize that if symptoms worsen or she experiences any chest pain, shortness of breath, or dizziness, altered mental state, she should call emergency services immediately, providing her with both written information and contact details for after-hours support as well. Now, we do have some comments coming in from the chat as well. We have here asthma action plan. And yes, certainly would be worth throwing in that you would be reviewing her asthma management plan, and part of that written information would best include that with her history of asthma there. There is thrown in the little bit of wheeze there. If you had delved into the history, it would have been a bit more vague and uncertain if there was any asthma there. For investigations, yes, things like a pro-BNP could be appropriate for looking into congestive cardiac failure. and urgent echo and chest x-ray, definitely very valid investigation options. You can access emergency physician via telehealth. Yes, this is a good answer. I dare say, though, that the downside to this particular case would be simply that this patient doesn't need telehealth. They need in-person investigations. They need auscultation of chest, imaging, pathology. This is something that's probably bigger than a telephone call, but I do like this option because it does also get a second medical mind listening in, and sometimes just hearing the same thing from multiple sources can be enough to convince some patients to say, actually, maybe I will go to the emergency department after all. So, yep, definitely things I think would be very good to throw in there. So, again, this case is not so much what you're answering. This case is really about displaying that you have a well-structured approach to these situations of uncertainty, which really is the bread and butter of general practice, that you are able to implement a safe and effective management plan for those patients who have that risk of deterioration, and to make sure, again, this is the last kind of safety check before you're released into the world as a fellow GP, that you're able to make sensible decisions to try and convince and redirect patients towards appropriate care. And if they still decline, as is their right, patients are allowed to make bad decisions, unfortunately sometimes, but to make sure that you actually have an approach to safety net these patients as much as possible. And I did mention it, but I want to really emphasize the importance of actually documenting these discussions and documenting your insistence the patient attend, but despite multiple attempts, the patient has declined. Very, very important. Some places you'll hear it called the care policy. Cover backside, retain employment, CARE. One way to remember it. But again, from that medical legal risk point of view, it is a very important part of this case as well. All right, so we'll wrap this one up here. And we do still have one last case prepared. I'll just see if anyone in the chat does want to jump in and attempt this one. If not, I can run through it very quickly. We do have Kesh. Love you, mate. You're happy to give it a go. I know you've already done it a couple before, so I think I might say don't worry about this one. I do appreciate the offer, though. Look, let's just talk through the... Oh, actually, sorry. I really should go through the feedback for this case. Let me switch the screen, sorry. There we go. So for this, the competent candidate recognises the need for the urgent assessment, providing a clear rationale for ED referral, creating that safety plan to monitor symptoms and escalate care appropriately if the patient does refuse. The communication is with empathy, listening to the patient's concerns, addressing the uncertainty with reassurance and understanding, using clear patient-centered language to explain the risks of delaying care, applying clinical guidelines for managing respiratory distress and emphasising the importance of urgent assessment while respecting patient autonomy, and developing an alternative safety plan that balances the need for care with the patient's wishes. There we go. So we'll quickly step through this last case then. I might just pop up on the screen. Let's bring that up to there. I'll put 5 minutes on the clock, or if I will just post one last time. If anyone does want to try and sit this case, I will pop the Zoom link in the chat. So if you want to give this one a shot, last chance for tonight. Jump in on Zoom and we can have a crack at it. While I give this a minute for anyone that might be tempted to join in, I will say that because I usually run these on Friday nights, I imagine you might have other things on your mind next Friday night. And so if people are happy here, I might actually schedule in to do the next live stream on Tuesday night. I used to do the Wednesdays, but I'm aware that GP Academy runs on Wednesdays as well. And so to give people as much practical time as possible, I'm booked up on Thursday night. I do apologise. So Tuesday is probably the last chance we'll have to have one last live stream, one last run through before the exams kick off. So, again, if anyone wants to jump in, the link for Zoom is in the chat. If you're having any troubles accessing that, let me know in the chat. Otherwise, in another 30 seconds, we'll just do another talk through of the case. And, yep, that's fine. So, let's talk through this case then. Now, this one you're going to find is a fair bit different to the others. But is something that is fair game in the exam, and you'll often find a question on a similar vein. It's something that's going to be a little bit different to your usual clinical encounters, but as a way to actually assess not just your clinical mind, but also your practice mind, your business and larger professional mind as well. Enough teasing you. Let's bring up the case. I'll put 5 minutes on the clock for reading time. Your time starts now. All right, time is up, and this case is probably going to throw a lot of people for a curveball. Rest assured, it's similar to the last case. It doesn't matter necessarily what you say, it's making sure you have an approach to this case that's sensible, rational, and shows some thought. So, bring it back up on the screen here. The first question here would be what would be your initial steps in developing this disaster management policy? And so the first thing is to actually start by conducting a comprehensive risk assessment to identify what are the kinds of natural disasters or relevant causes, in this case, most likely cyclones or floods. And that would involve reviewing past incidents and consulting with local emergency services. You could also engage with local key stakeholders such as clinic staff, local emergency responders, community leaders to understand current capabilities and potential areas for improvement, and audit the clinic's current resources, including medical supplies, communications tools, backup power systems, which would be essential to gauge your clinic preparedness level. Next question then is what are the essential elements that should be included in such a policy? And so the policy should include the emergency response protocols, so clear steps for staff to take during a disaster, such as patient evacuation, securing medical equipment, and assigning roles such as an emergency lead, a communication officer, organising continuity of care, so procedures to maintain essential medical services such as securing access to chronic disease medications and emergency care for high risk patients. A communication plan, so internal communication for staff such as group messaging platforms or satellite phones, and external communication for patients in the community, whether this be coordinated locally with radio announcements or social media. Resource management, so strategies to maintain adequate supplies of medications, water, and fuel for generators. And in terms of partnerships and support networks, details of collaboration with nearby clinics, hospitals, and other local authorities for resource sharing and backup support. Next question would be, how would you ensure that the clinic staff are prepared for future disasters? So this would involve implementing regular training sessions and simulation drills to practice for emergency response protocols, and also to help identify gaps to build staff confidence in their roles, and cross-training staff for multiple responsibilities to also provide flexibility during a crisis. Additionally, all staff should be up to date with their first aid and basic life support training. Next question is, how would you involve the community and local partners in the disaster management plan? And if you've done a bit of thinking, you may have already covered parts of this from previous questions, but engaging the community and local partners would involve holding information sessions to educate residents on how to prepare for disasters and how the clinic will function during a crisis, building partnerships with local governments, NGOs, and emergency services to ensure a coordinated response and resource sharing. Recruiting and training any volunteers as well from community could also provide additional support during a disaster. Continuous review and improvement then. So what measures would you take to keep the policy effective and up to date? And that would involve scheduling routine reviews such as annual or following any disaster or drill to assess the policy's effectiveness. Feedback mechanisms from staff and patients post events would also inform updates, and to ensure that lessons learned from each incident are incorporated into the policy to keep it relevant and robust. And of course, what challenges might you face in developing and implementing this policy, and how could you address them? Well, challenges could include, surprise, surprise, limited funding for primary care, which would also impact on resource gathering, such as backup generators or additional training. To address this, you could explore grants and funding opportunities from local governments and NGOs, but another barrier could also be, of course, staff resistance to new protocols. This can be mitigated by involving staff early in the development process to give them input into how they feel things should run as well, and highlighting the importance of their safety and the importance of continuity of patient care. And that would wrap up the case. So again, yes, it's a bit of a curveball, bit of a doozy, but really it's about thinking through how actually would you approach it, and starting from that kind of preparedness level through to what other resources are available and how can we use that to provide ongoing patient care. This is one that the questions will often guide through the kinds of responses that people are looking for. And so as long as you're coming up with some kind of structure or sensible kind of approach to it, I think you're going to get through. Each exam has one or two of these curveball questions that are designed to trip you up a little bit and to get you thinking in a way that you may not have necessarily been prepared for. Now, we do have in from the chat here from Keshminda, have a town meeting with paramedics, local hospital, fire and police. Fantastic. And monthly meeting would be good. Yes, that having those regular contacts to provide continuity as well, particularly in rural remote areas. Staff turnover is a problem. And as old staff leave, new staff come in, it's also a great opportunity to bring them in and get them up to date with what's going on. So I love that response. Having a one-stop centre as a triage to answer question 2, also fantastic. As point number 2, yes, it's always important to try and build redundancies in as well, because you never know if the one-stop centre gets taken out in a disaster, does the whole plan fall apart? And of course, it would be good for the clinic to have a backup generator or solar panels with battery. So yes, again, ensuring that ongoing power supply should the other standard kind of ways to build energy gets taken out. Brilliant. We'll stop the clock on that one then. So there we go. Now, for the exams, it's not always a question quite like that. Now, RACGP do actually have a disaster preparedness for clinics kind of module that they encourage people to read through. But if you actually go through the RACGP website, for the information for practices, you'll often find things like this that may just appear in exams. You'll see some of the topics come up from time to time. For instance, one of the other questions that has been seen before is things like a complaint's put to the clinic. How would you set up a policy to make sure complaints are appropriately handled? And so again, it's more thinking through that systems approach to running a clinic, almost looking from that business side of thing, as if you're one of the practice principals. How are you going to actually run the organisation, not so much just the general patient care? And with that, we might wrap it up for tonight. So I appreciate everyone coming up. I know Saturday night's probably not the best night to be doing these live streams. I appreciate as well Keshminda for offering to jump in on that last one. You're probably very grateful you didn't now, but I loved your responses there, and definitely keep up the good work. So look, enjoy the rest of your Saturday night. The next live stream then will be Tuesday night, 8:30, the usual time. I'll have another 3 cases prepared, and I look forward to seeing you all jump in. Please, please, please take the last opportunity to get in, do some last minute practice using Zoom as we would on the exam day, and make sure you hit next weekend with full force. So catch you guys then, and stay well until then. Take care.